Well, good morning. I could try and make everybody come down to the first and second rows, but I won't do that. It's just sort of, okay. Anyway, so I am Becker, and I'm in my capacity as Program Director for our Addiction Medicine Fellowship, happy to introduce Dr. Brian Grahan, who is our current Addiction Medicine Fellow and has been here since last July. Throughout the years, he's been very active in terms of health service research, and particularly as it relates to addiction. He completed his MD and PhD at the University of Wisconsin and then came to the University of Minnesota for a Med-Peds residency program, and then last year was chief resident mainly out at the VA, is that correct? Mm-hmm. Working on quality improvement issues and patient safety. His focus has been on measurement and implementation of quality and patient safety efforts within health systems. So this year, as part of his fellowship training, he received an award from the Conrad Hilton Foundation to develop screening and intervention techniques in populations of alcohol, so adolescents with alcohol use problems. So I'm very happy to introduce Dr. Grahan, who is going to be talking about his project and his work in the adolescent substance use area, recognition, brief interventions, in adolescents. Dr. Grahan.
Thank you. So I'm going to, my primary goal today is to keep you awake. Secondary goals is hopefully education. But I want to just talk to you today a bit about adolescent substance use, because I think in general it's just a really challenging time, both from the developmental standpoint. Interpreting substance use is really, really difficult, especially when you start getting into what type of substance use is this a use disorder, is this problematic, like what all goes into that and what do you do about it? Lots of overlapping issues. I have not yet won the Nobel Prize, so I have not yet solved this problem. Hopefully though, I'll give you a general sense of kind of our current thinking about this, or the way oftentimes people are starting to think about, and give you a couple specific tools about where to go from here in your clinical practice. So disclosures, I have no money in this at all. If you want to give me money to spend more time on it, that's great. We can talk afterwards. And while I don't have adolescents, I've worked a lot with adolescents, but I do have a three-nader, so I'm starting to get a hint of what this is going to be like. So I have a little bit more insight than perhaps some. Learning objectives. The three things I hope that you walk away with today, not necessarily what I'm going to talk about, but what I hope you walk away with, so I'm going to be kind of repeating some of these themes over and over through the talk, is one, that you feel comfortable screening adolescents with validated tools. What does that mean? I'll talk about it. Two, describing brief interventions. Hopefully, I'll give you some scripts and words that you feel more comfortable talking about it with teens. Oftentimes, the hardest part is just figuring out what words am I going to say. And then three, I'm going to talk a bit more about, given kind of all the attention that's being paid to opioids right now, is what are some things and kind of what are the current office-based treatments and some other treatments that are available for opioids specifically. There's going to be a smattering of other things, and I please welcome other questions as we go and afterwards, because I think there's lots of nuance and other things that come up related to these. Alcohol, marijuana, other. So just to start out, this quote was from a physician who was being interviewed. He actually lived in the town, the city in Vermont that had the highest rate of opioid use. It's one of the top 10 in the country. And he said, I just don't think it's that big of a deal. I imagine in the psychiatry world, it's more, people are generally more aware of it than in the general primary care setting. However, it's often still under-recognized. And even when people do recognize it, it's oftentimes this perception. It's just those kids. It's not my kids, it's those kids. I wouldn't really my kid would never do that. Super common, both among parents as well as providers. Again, it goes back to the screening. So I'm going to keep coming back to this, but I think it's just being aware of kind of what are the realities that we face when we talk about, hey, you should do more, you should screen more. People are super busy, and why should I care about that kid? Because the great, great majority of kids in primary care a little bit higher prevalence among the psychiatric setting, are negative. They don't use. It's not that big a deal. So oftentimes we make the argument that yes, it is important. It's a hard argument to make, especially when you say, well, what do you want me to do about it? We're just starting to approach the Prozac moment in substance use, where before that in primary care, you never asked about depression, because what are you going to say? You're depressed. Good luck with that. So where are we going? This is not about opioids, but it's about e-cigarettes, and it's about nicotine. And I think it's hugely important. I'm going to talk about nicotine, I'm going to talk about alcohol, and I'm going to talk about marijuana for a minute before I kind of keep going and talk about everything else. But I think it's important to realize these three, because oftentimes these are epidemiologically what people recognize as gateway drugs. Lots of discussion about what is the biological, what is the neuromolecular, what is all the mechanisms of gateway drugs, but oftentimes people argue these are the gateway drugs. Regardless of how you feel about that hypothesis, it's oftentimes the first substances being used. So what does that mean? Interestingly, in the last 18 months, the landscape has totally changed. Since 2011, with the introduction of e-cigarettes, totally different landscape. Cigarettes historically have always been there. But e-cigarettes now, the predominant form that kids get introduced to nicotine, adults as well, people that have never used nicotine products before are now using e-cigarettes. It's not just people are switching, new people are starting, and we have no idea where that's going. Also, flavored little cigars, the cigarillos, the Swisher Sweets, if you will. No, it's not a commercial. I don't have any money in it. But this is interesting because oftentimes people pay attention lots to the cigarettes, but if you look, it's actually almost the same now. Why is that? It's because there's cigarette taxes, not tobacco taxes. So little cigars actually cost way less. It costs, if you're a 2-pack a day smoker, it costs about $100 a week. You can get about a month worth of nicotine from your e-cigarette cartridges. You get about 2 to 3 weeks out of the flavored little cigars for that amount of money. If you're really cost and price sensitive, as most adolescents are, it makes a big deal. What does that look like? Boom. Cigarettes, a long trend. Cigars, those little cigarillos, actually about the same. So everybody's really been encouraged because they've actually taken a really big drop in the last year or so. But why? It's because now they've been replaced. E-cigarettes, we have no idea where they're going. More to come. I'm not going to spend, it's a whole other talk unto itself, but just be aware of it, especially since anything that can be put into a solution, a hydrophilic solution, can be vaped. Kids are using amphetamines, vaping them. Methamphetamines, vaping them. You might see a little sidecar cartridge on the e-cigarette. That's for marijuana. Smokeless, tasteless, flavorless. Well, you can get flavors. But you can do that in the high school bathroom. Nobody would know about it. Just something to think about. 2, marijuana. That was a little bit aside, but the important thing is kids are still using a lot. If you look at that last slide, it's still, if you total that up, it's not always overlapping. People are about 30% of kids are starting to use it. Marijuana, you look at annual use, 35%. So it's almost 2 in 5 kids in 12th grade. 1 in 5 kids in the past 30 days. 1 in 20 that are using it daily. That's a pretty high number when you think about it like that. 1 in 20. What does that mean? I don't know. We're still figuring it out. Alcohol use. Annual use. Definitely about 2/3 of kids are using it annually. People say everybody tries it sometime. But did 1 in 5 kids binge in the past 2 weeks? And that, by the way, is defined as 5 or more in a sitting, the way this was from the Monitoring the Future study. That actually changes. The younger you are, actually, the lower the number. So this 4%, this is also based on 5 or more drinks in a sitting. Yet if you're an 8th grader, usually the definition of binge is actually 3 or more from a physiological standpoint. So that 4%, 1 in 20 is actually an underestimate. Think about it. It's a different kind of setting. And oftentimes when people start thinking about screening for it, it's when you hit high school, especially the older high school. Oh, you're junior, senior, you're probably getting ready to go to college. That's when most people are going to start drinking, right? Wrong. Interestingly, but average age of drink is 14. If you're drinking when you're a teenager, the average age that you start drinking is by 14. Almost 2/3 of kids have already started drinking by the time they're 15. When do we start screening? Usually after that. And what are you really concerned about? It's actually the biggest concern that you have is actually the earlier you start drinking. I'll touch base on that in a moment, but here let's talk about opioids for a second. Alcohol, sure, it's been around the block. Tobacco, it's been around the block. Opioids, kind of the new kid. 2004 to 2011, this is data from 2011, 13% of teens, or kind of ages 12 to 21 in this data, 13% of people say that they had used in a non-medical way. Not necessarily non-medical, like I wasn't prescribed using it for pain. This is, I wasn't prescribed it and I'm using it for other purposes. 13% of those kids actually started 8, 9, 10, 11, 12. When do we start screening? For opiates, usually never. But when to start thinking about it? Again, it goes back to the beginning. So really when you're talking about what is the impact that this has, and why do I keep going back to the earlier? One, just kind of on a visceral level, people oftentimes see like, God, a 10-year-old? An 11-year-old? I think there's a visceral reaction that I hope you have. But two, I think it makes a big difference. Because earlier onset has a big difference in terms of how it plays over time. And this gets to neurobiology. So substance use changes the brain, and addiction is a brain disease. More and more data is coming out about this. I'm not going to go into it. But I'm talking to an audience that's probably more in tune with neurobiology than most. However, for a lot of people, it automatically triggers this. Neurobiology. What is that? That's your amygdala talking. Automatically, poof, passed out. I feel like most people that have gone through med school training. But why don't you? Because I don't see anybody asleep yet. I'm hoping to prevent that. But why don't people? That's actually kind of prefrontal cortex working to say, like, that might be an awkward moment if I fall asleep right next to my program director. I'm trying not to fall asleep. But I think that's kind of where it comes in. So this is actually your prefrontal cortex at work, is that you're not being Homer right now. And seriously, I promise, it's interesting. But it's because it goes back to here. So why do I care about substance use early on, especially in adolescents, when I've already told you that the great majority of kids, 2/3 or more, I'm not actually concerned about their substance use? Why am I still concerned? It's those early kids, even though almost very few people are going to screen positive, but it's because of this. Your synapses really kick into full gear, 6 years old, and then suddenly people start doing that synaptic pruning, trying to figure out, what do I really need? People probably in this audience especially were aware of kind of the recent data coming out, I think it was published in Nature, around schizophrenia. You know, an abnormal autoimmune response now is selectively pruning things so you develop schizophrenia, having psychotic breaks. What's really going on? I'm sorry?
What brain area is that slide from?
This exact study,
What area of the brain?
what area of the brain you're talking about?
The brain?
Yeah, like, you know, is that, they look like granule cells to me, so is that in the frontal cortex, or where is that?
To be honest, this was a representative slide of the full development, so I think there's more data talking about the development more on very specific regions of the brain. I wasn't looking to say the specific type of cells that were developing and being pruned.
And do you know if it's a male or female brain?
I did not go into that.
Okay. Both of those issues are kind of important for the
True, but I think the point that I'm making here is really in terms of what are the timing of the effects and the development in different regions of the brain. I think the timing is what I'm emphasizing by this slide, not necessarily the type of cells and the gender in terms of what you're talking about. But I think broadly speaking, and again, this is a generalization, understood, it's kind of that pattern of development as you kind of walk through from toddler, preschool, school age, and adolescent. What types in general are developing along what time frame? Understand, there's lots of variability in terms of what you're talking about here. But I think in general you can walk through in terms of saying what are the things that are really being accentuated as you walk through these types of developmental stages, and when are you really affecting? So the ages that we're talking about really fall into kind of this late school age and early adolescent period, is when people talk about what is the impact on the development. So say, for instance, alcohol. If you start drinking before the age of 14 and you have a positive family history, you have about 50% chance of meeting the criteria for alcohol dependence in your lifetime. Just waiting and the curve starts declining. If you don't have a positive family history, so theoretically you don't have the genetic loading to have a use disorder, a severe use disorder, You still have a 25% chance of meeting the criteria for alcohol dependence if you start drinking by the time you're 14. It makes a difference. We're still trying to figure out exactly what does that mean at the neurobiological level. I can tell you there are studies looking at nicotine priming for cocaine, alcohol priming for cocaine, that at the neuromolecular level there's definite pathways to say why is this a gateway drug. It's still being worked on for other types of medications or other types of drugs, but it makes a difference in terms of how that plays out. And especially if you think about it in the adolescent developmental context, oftentimes risk-taking behavior is skewed. So adolescents oftentimes developmentally appropriately have a predisposition towards risk-taking behavior. Oftentimes because kind of the motivation, kind of the nucleus accumbens and reward systems are more developed than the prefrontal cortex and impulse control. I'm making that generalization. I know there's lots of variability in the studies here, but I think here is just one representative study by Galvin, which, that was done in 2006. There's subsequently been more work, but I think this picture paints a nice portrait, a representative portrait. So this is a study done where kind of you can see these various ages. There were 17 children, 7 to 11, 13 teens, and I think 20 adults that were put through an fMRI using a simulation study looking at the magnitude of reward based on different cues. And interesting, I think the story that's told is really probably what people already know from their own experiences. If you give an adolescent a small reward, they learn pretty soon to blow you off. Kids, though, they're pretty much just as happy, and the kids of the blue line, they're just as happy with a small reward as they are with a large reward. They just kind of keep trucking. Adults kind of know that there's a graded response. Kind of if you looked at medium, which there's a medium response in here as well, it kind of gradually rises. But if you give an adolescent that large reward, it really spikes. If you look at the reaction time, similarly, small rewards, kids actually learn to react slower to small rewards. They pick up with large rewards. All this feeds in, I'm not going into all the studies, but people have started looking at more and more, what are the risk-taking behaviors in the neural, at least the imaging, that correlates with these types of risk-taking rewards, and it's this similar pattern. The nucleus accumbens activates faster than the prefrontal cortex, orbital frontal cortex. This was matched with OFC data, other different small regions of the brain. We're still trying to get again to the neuromolecular level, but this consistent pattern is coming out from the evidence. Kids are predisposed to react strongly to substances of abuse, especially ones that they're primed for, whether it be genetically or epigenetically. The reward is context-specific as well, which makes it challenging. So anything that I say in my office, if you go to a party, they might be totally honest with you and say, you know what, I never want to use again. But suddenly when I'm in the context of my friends, and there's a drink, there's the girl over there, and there's the guy over there, and I'm really interested, the decision might be different. They're not lying to you. The context is different. What's the reward? Beyond just the reward, it's also just different from why should I be concerned about any drinking? This really underpins why we say don't drink at all until you're 21. Why the AAP and people are pushing it. It's this graph in particular. Because at any given drink that you have, the younger you are, the more effect it has. And this is not just a physiologic response. That correlates with this. This is actually a relative risk of fatal crash. It makes a big difference. Even if you're not interested in the long term, the short term, I just like to keep my patients alive. What does that play out? Top 4 out of the top 5 reasons for mortality in ages 10 to 24, all related to substance use. It makes a difference. If you're looking at opioids, more and more are out there, because we just prescribed them for a long time and we thought it was the 6th vital sign that was valid. Lots of issues with that. But now there's no more non-medical use. About 2/3 of the time when people ask the general question, is this non-medical use, meaning not prescribed for you? About 2/3 of the time teens use it for pain down the road. Not necessarily an issue. 1/3 of the time they use it to get high. So it's that substance that you're really interested in. Among those kids, there's more poisonings, greater ED utilization. Poisonings and ED utilization has gone up by about double in the last 3 years. More admissions associated with that, and suggestions of more use disorders. There's a higher risk of transitioning to heroin. Use disorders is probably a little bit too strong, but there's a higher likelihood of transition to heroin with any non-medical use, especially if it's not for pain. Here's what I was talking to you about before about alcohol. Why do we care? It makes a big deal. Screening early is important. Catching it. Interestingly, it's actually a pediatric disease. The y-axis here is confusing. I won't go into why, but I think the study that was done, it's slightly pushed to the right for alcohol. This is drugs in general from the NESARC data, the National Survey of Epidemiologic and Substance Abuse and Related Conditions. But I think it's important to realize that the great majority of people that meet the criteria for dependence actually is between the ages of 18 and 24. It's kind of interesting when you frame it like that. So enough education. What do I do? I think this is really the hard part, especially in adolescence where clinical trials are so much harder to do in this population. So a lot of times we're just kind of winging it. So if I haven't lost you yet, I firmly believe that we can't totally treat our way out of this epidemic. Oftentimes people say, well, we just need to refer people to treatment. We don't have the resources for that. Moreover, oftentimes people are not interested in the resources that we offer them. So what do we do? This option's been out there for a while, but I think it's stickier than it's easy to say, hard to do. Screening, brief intervention, referral to treatment. Almost no studies have been done on referral to treatment, by the way. I'll touch base on that a little bit at the end. But we actually have no idea how to refer to treatment, what that means. Screening, brief intervention, what does that mean? 1, screen. Clinical impressions, pediatricians, 103 pediatricians looking at about 550 kids. Test characteristics are horrible. We do not know it when we see it. We do not know it when we see it. If we're catching about 14% of any problem, 10% of the time, a kid that has a use disorder, we have no idea what we're looking at. Interesting data that I'm not going to show here, studies from the American Academy of Pediatrics, about 88% of the time pediatricians say they screen for substance use. Only about 23% of the time do people use a validated screen. So in the push to screen more, people are asking, hey, do you? What's the right answer? Do we catch it? No. Arguably, however, most of the time kids don't use. So how do we catch it? What do we do? A couple screens. The Craft, probably the most well-publicized that's out there. Probably Cage is even better publicized. However, that's horrible for kids. Craft. If you forget all these, I hope you remember at least the first question. Have you ever ridden in a car with somebody that's been using or you've driven yourself? That's how kids get in the accidents that lead to mortality, serious morbidity. However, the range of these, the number of these that are positive, directly correlate to the likelihood of a higher severity use disorder. It's been demonstrated with diagnostic interviews in a couple different studies. However, it still requires 6 questions in a clinical setting where time is of the essence, especially if you had to deal with the parents first and now you're getting like 5 minutes with a kid. And now you're asking 6 questions when you also want to ask about safety, abuse, all these other sorts of things. So what do you want to do? Interestingly, the S2BI came out. 2014 it was published out of the Boston Children's Group. They found that actually in about 5,000 kids that they tested on, asking only about those 3 questions, these 3 questions that I brought up at the very beginning, which is why I pushed them. If you ask about tobacco, alcohol, marijuana, if a kid says never to all 3 of those, this never was positive. Never was positive. So how do you triage? 3 questions. Ask never, once or twice, monthly, weekly. Are there going to be exceptions? Sure. Rare. Very, very rare. So in putting this into a clinical setting, focusing on these 3 questions are the highest yield you can do. And what do you do with that? No use? It doesn't mean you leave it there. It means positive reinforcement. Great call. I'll talk about how I use those words, or what I think that means. Once or twice in a month, or in the last year, you ask the follow-up questions, brief advice. What's the difference between brief advice, brief intervention? I'll touch base on that in a minute. If they use monthly, weekly, suddenly now you're in the category where you're thinking, gosh, are we in the use disorder realm? Are they in kind of the use disorder realm? It gets a lot harder to diagnose in the adolescent, but I'll get to what I mean by that. Here's some test characteristics. Sensitivity for S2BI, any use disorder or severe use disorder, 90 to 100%. Compared to anything else, it's better. Cage only catches about 67%. The standard thing that's done in the clinics upstairs is the cage. Be aware of that. You're missing a lot. So, take for example Tamara, 12-year-old girl who did not use substances in the last year. What do you say? I would ask one more question. Do any of your friends drink? Single best predictor of in the next year, is she going to start using? Do your friends drink? Do you know people that use? In this age group, it's peers. Make a huge difference. If she says no, great decision. Most kids your age don't drink. I'm glad you're choosing the healthy options. Simple, quick, positive reinforcement. Ryan, however, is a 13-year-old boy who's getting drunk in alcohol 1 or 2 times in the last year. What do you do for him? I'm concerned about your drinking. Well, you can decide what to do. And there's some words around this called, what I like, I think my favorite mnemonic is the frames discussion. Now, people have varying degrees of beliefs and how they think about the frames discussion, but I emphasize this because in motivational interviewing, especially when you get in towards the use disorder for adolescents, it's been proven to be more effective than brief advice. And more kind of the emphasis is generally you have better outcomes if you put decisional control in the hands of the kid. And especially you kind of shift that locus so it's more on them. Make them figure out the norm reference, make them figure out the decision they want to do and set their own goals. So how do you put it in their court while still emphasizing what you want? Hard conversation to have. But I would come up and say, you know what? I'm concerned about your drinking. Now, I get it. Only you can decide what to do. It's your life. I would recommend that you wait until 21. You know, there's reasons for that. Here are my reasons. Now, you know, you can continue, drink, it's your risk. I would wait until you're 21. Your call. It's your decision at the end of the day. But please, please promise me that you're not getting in the car, that friend that's been drinking, or if you've been drinking. That's how we don't get that next conversation. I totally get it. It's not an easy conversation. You might be feeling a little uncomfortable right now. I feel a little uncomfortable. It's always a hard one. But it's not easy to do what your friends want you to do. I get that. At the same time, you're a smart kid. You know the facts. We've talked about it. You've heard it from other friends. I hope that you make the right call. Decisional control is in their court. It's their goal. Where to leave it. This is what I call brief advice. There's data out there saying that you can even make it even shorter than that and just say, like, you know what? I really hope that you don't drink. And leave it at that. 2 minutes. In older populations, kind of 25 and up college age, that, as small as that, with 2 phone calls and 1 follow-up visit, as short as that, had an effect that was durable out to a year. In adolescents, not as clear. Again, it goes back to that decisional control. In adolescents 7 to 18, the meta-analyses that are in there, and granted, the data on this, the studies that have been done are not that great. So take this all with a grain of salt. But the best meta-analyses that are out there show that about 1.5 fewer past drinking days in the past month for adolescents 11 to 18. So kind of a mild to moderate effect. Again, the things that made a difference when they kind of teased out what are the things that each brief intervention focused on. Decisional control, goal setting, personalized feedback, norm referencing. What falls out when you get into that slightly older age group? 1, it's not as effective. 2, norm referencing doesn't matter. These are the kids that is college age, so it becomes normal. If you tell them about the norm reference, they think that's abnormal. They assume everything is just to you. If you look at the younger kids, oftentimes they believe more because they know more kids that aren't drinking. It's more about expectancies in the older age group. This is kind of the young adult. Most of these studies have been done on 18 to 25-year-olds, college-age kids, mostly college kids. Very few studies have been done on kids or individuals that age that are not in college. But expectancy challenge, meaning what do you expect? Is this going to be a positive experience or a negative experience if I drink heavily? If you can start flipping that and focusing on what people expect, that expectancy challenge is when people get more of a benefit. So Yasmin, 15-year-old girl who smokes marijuana a few times per month. What do I do for her? This is the case, especially for marijuana, it becomes an incredibly challenging conversation. Marijuana is a super hard conversation right now. 1, especially if you're smoking this much, screen for mental illness, family substance use, ask about peer behaviors. This is for any substance once you get into the monthly. The likelihood that there's a comorbid mental illness goes way up. Like 30+% in this age group. And how do you frame this? Again, I think going back to frames, but here I do a little bit more of a nuance to it. Because here again, we'll go back to it. I'm concerned about your use. Now I get it. You control your own life. Totally your call. I would recommend that you stop. Because taking in the smoke, all those other things, we can talk about likelihood of psychosis, all that stuff. But at the end of the day, it's your call. So I know it's a hard conversation to have, but I hope you make the right call. What would you be willing to try to change? And oftentimes, even before I ask what would you be willing to change, I ask what do you like about it? Because sometimes they'll tell you, oh, actually, I'm treating my anxiety. Oh. You know what the funny thing? It's like alcohol. Alcohol is a great drug for anxiety, except that it kicks you in the behind on the way out. It's a great drug. People get anxiolysis right away. Acknowledge it. Because most kids, when they say marijuana is a bad thing, alcohol is a bad thing, they're like, well, it's helping me. And oftentimes at this stage, they haven't had the physical tolerance and the physical negative effects. Usually it's social things, which can be more normative. So oftentimes acknowledging what the benefit, asking that up front, often takes the edge off of their initial fight. What do you like about it? What don't you like about it? Sometimes people are like, there's nothing bad about it. Okay. But wouldn't it be nice if I could give you something that actually did that better and easier? It just gives you an entree. Again, it's super hard on these kids when they're already primed to risk-taking. Why would they take something from the man when they can do it with their friends? But it offers you that entree. It starts the conversation so it's not an initial blow-off. And then what would you be willing to try to change? Again, decisional control. If they say nothing, fine. But you know what? Come back in a month. Oftentimes it's continuing the conversation. Oftentimes failure in any given visit is the norm in this age. The hard part is keeping him coming back. Because oftentimes when they start having trouble, it's keeping him coming back. Now you can offer the benefit. Assert yourself, but not necessarily in an aggressive way. It's saying, hey, let's find that decisional control point where we're both in this and keep going. And then we get to John, 18-year-old guy who uses opioids on most days. And John's not one of the 2/3 of the kids that are using it for pain down the road. He's using it because he likes it. Maybe initially he started it. Oftentimes, more likely than not, kids are actually athletes or have an acute injury and they just realize as the pain starts wearing down, they actually get more benefit. I've had a number of people in the burn unit that I take care of that actually as the pain starts decreasing, they start realizing they like it. That's interesting. Oftentimes a common thing. So here's how I think about substance use diagnoses in this case. And I think this is where it gets into misuse versus use diagnoses in this age group. Very hard to do. Note that I did not put all the 11 criteria for DSM. I think it's more helpful for our purposes here to remember the 4 key areas, because oftentimes if you start asking about these, you kind of get the gist. Where am I going? The things that I ask in addition in this age group, because it's oftentimes hard to get all these criteria, because they're more predisposed, since oftentimes it's illicit, to get social impairment. Risky use, more common. Normative. The hard thing to get out of this is impaired control, and this is where you start getting into the risk factors. 2 generations of family use of use disorder, your likelihood of having a use disorder yourself goes way up. Far more likely to have impaired control. Early drug exposure, the same thing as where I went back before. You're changing the way your brain is developing, you're changing the way, I'm not going to go into details, but you're changing that risk-reward system. You have a higher likelihood of doing so. Comorbid mental illness, big deal. Adverse childhood events. About 2/3 of kids that have 4 or more adverse childhood events from the ACEs study go on to have substance use issues. So how do you think about it? So for him, for John, I still go back to the motivational interviewing, but this motivational is a little different. You're still asking what are you willing to change, but oftentimes the motivational interviewing for somebody that has a moderate to severe use disorder, that I think is actually use disorder, meaning impaired control over their use. Not I'm drinking a lot, but actually can't stop drinking. It's a nuanced but incredibly important one in this age group when you're diagnosing use disorders. It's actually increasing engagement and reducing use. The likelihood that that kid, through motivational interviewing, is going to stop using is pretty close to 0. It's early on, but here's where you're really trying to connect. Follow-up is super, super important, especially when you're going to the adolescent kind of psych clinic. If you're going into the primary care, involving the family becomes far more important. Checking the prescription monitoring program. If you don't have your DEA, the pharmacist that works with your clinic definitely does. You can ask them to publish to get the PMP reports for you. It lists all control that have been filled within the last year in the state of Minnesota and our surrounding states. Medication-assisted therapy, which I'll talk about, not as evidence-based in teens, but can still play a huge role. And then consulting a specialty care team, and I'll talk about what I mean by that. The other thing that oftentimes becomes more important in this age group, I think it's not evidence-based, but I think anecdotally can be really important, especially if you're an older person, which means all of us in the room, because we're all older than them. It becomes that awkward conversation. Showing them a video is oftentimes a depersonalized way to give them access to say, what is the information I'm thinking about? It takes you out of the picture, and it's a modality they're used to watching. I've now got videos that are put onto my smartphone that sometimes I'll just show it to them. I'm going to go document this note. Here, take a look at this. Just another way to access the kid, because oftentimes that first conversation is the hardest. But here's oftentimes what people say. It's brief intervention. So I've had this motivational interview. I think you're a little bit more than that. I think you should go to rehab. What the hell is that? Oftentimes people feel this, it's because this is the industry, this other feeling, this stigma associated with it, people oftentimes say like, whoa, 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 I might have a problem, but it's not that bad. Or you want me to go where? Often as providers then feel like, well, I don't get any feedback. So all I know if they're using it is that they show up again. It becomes a really difficult conversation to have in some cases. I think in rehab, and by rehab I think I use probably the most stigmatized wording for that, but oftentimes outpatient or residential treatment has a role. It's an incredibly important role, especially in teens that I'll go to in a minute. But what do you do in between? And I think here is where you get to individual counseling and medication-assisted treatment. Things that you can do through your office. Follow up in your office. Offer medications, offer counseling. Be hugely powerful. For opioids, buprenorphine, naltrexone. Buprenorphine is a partial agonist, the mu opioid receptor and kappa and a couple other things I won't get into today. Naltrexone is an antagonist. Evidence for buprenorphine. The best part about it is a kid that really does have a moderate to severe use disorder for opioids. Sometimes the likelihood if they become abstinent, the likelihood that there relapses, in more adult studies than teens, is 80+%. Not great odds. The hard part, as I talked about, is how do you know that that kid has a moderate to severe use disorder? Super hard. That said, if that kid's really having craving, has tried multiple times to get off, hasn't been able to manage it, buprenorphine is nice because now suddenly it can manage those cravings. It gets kids stable. Chronic use of opioids actually dysregulates your hypothalamic pituitary axis, so you get dysregulation of your stress response. So oftentimes the exact negative affect that you feel by trying to get off, you're already primed to relapse. Buprenorphine actually normalizes all of that. So the kid feels normal. The adult feels normal. The hard part again, how do I know a kid has gotten to that allostatic state? Difficult question to get to. Which brings in naltrexone. I'm not sure they're at that point, but they're using it in an unsafe way. Naltrexone blocks the effect that they're going to get from any abusable opioid. However, if they do have dysregulation of their HPX, or their stress response, it doesn't help with that at all. It doesn't help with cravings at all. So the kid may still be jonesing for it. The interesting thing is then, naltrexone, you actually normalize your receptors. You don't have tolerance anymore. The kid that comes off naltrexone suddenly, or say for example residential treatment, they're the ones that are high risk for overdose. Because they go back the majority of the time to what they were used to using, and now they can't tolerate it anymore. Tough to weigh. Which one is appropriate? I think in the field, oftentimes people say, well, you know, we want to push naltrexone because who wants to put a kid on a long-term opioid? I get it. The question is, nobody actually has any idea what happens when you block the opioid receptors in a teen. We don't know. So I think it's an uncertain argument. What's the right answer? We don't know. Interestingly, there's no real good studies on naltrexone in teens. So I can show you just two small studies on buprenorphine. This is in a group of 13 to 18-year-olds, only 36 kids. There's only 2 studies out there, so this is pretty good. They only did it for 4 weeks as part of a detox protocol, switching kids at the end of it to naltrexone, depot naltrexone. Here, About 72% of the kids made it through 4 weeks on buprenorphine and maintained on treatment. 63% of those ended up going and committing to naltrexone. Pretty good retention in treatment. Clonidine, about 37% of the kids made it through the full 4 weeks, still engaged in treatment. Only 5% of them committed to naltrexone. If part of the huge part about, especially in teens, is keeping them coming, I would argue there's a clear winner here. Buprenorphine, again, this is in a 12-week trial. They did detox where they maintained kids on 2 weeks of buprenorphine, then tapered them off, then followed them. Buprenorphine for 12 weeks in the maintenance group maintained to a peak of about 16 milligrams, and then tapered them at the end of 12 weeks, and then followed them up in an outpatient setting. Here again, you can see the likelihood of dropout, detox was about 80% dropout. Again, this is not retention, this is dropout. If you look at the buprenorphine group, only about not quite 30% dropped out. Again, why I picked this instead of opioid positive urines is maintenance and treatment is a huge piece of the puzzle in adolescence. The likelihood of relapse is super high. Polysubstance use is more the norm for all the reasons that I said before. Retention is huge. Yeah?
Sorry, I didn't keep interrupting, but I'm trying to understand things.
Uh-huh.
I'm not sure what you like is that just
So the detox protocol in this study, they got kids up to about 8 milligrams of buprenorphine, and then within 2 weeks they were off to nothing. So there's a short-term detox, so kids came in all using heroin or prescription opioids in a non-medical way. And then at that point, they randomized them to either maintenance of buprenorphine for a short-term, 12 weeks, or kind of a short-term detox where they'd get them and then they'd help a facilitated withdrawal protocol using buprenorphine. So they'd taper them off rapidly. Yep. Yep. Uh-huh. They did, and that. Yep, and this played out. They actually did 3, and they actually did 6 and 12-month data as well. And they still had a higher, the maintenance within the buprenorphine group, once they stayed, was about 50%. In the detox group, it was like 10. I think it was 9%. So it wasn't just acute withdrawal. And even if you look at here, this should be the point which everybody stopped, if you're talking about withdrawal. And it wasn't. Sure. Sure. And again, why would I pick buprenorphine versus an antagonist? Again, it's kind of maintenance. So I think it's retention and treatment. I think that's exactly part of the point. How do you learn more about this? I just want to put these up here for learning beyond here, because this presentation is not going to change your practice necessarily, but I hope that you keep learning about this, whether it be for adolescents or going forward. I think here's where you learn more. Great references, national experts. You can even ask for individual mentoring from somebody in your region if you want to look through these websites. Comorbid mental illness, also huge issue. Treat it. I think all of you in this room are learning to be psychiatrists. I'm learning how to do that. Keep it up. High-risk conditions here, again, any mental psychiatric illness, it's going to have a higher likelihood. But these are some of the key ones that have particularly high prevalences of comorbid substance use disorders. We're going to talk about counseling, individual therapy. I'm not going to go through the evidence here, but motivational interviewing has better evidence, cognitive behavioral therapy has better evidence, contingency management has better evidence. All the evidence there for adolescents in particular, not that great. We're still working on it. Not that many trials out there. Specific to families, best trials out there are multi-systemic therapy, multidimensional. However, it varies by the type of family. Just know that it's out there. When I say referral to care team, I think there's other options than kind of when people think about, I need to send you to treatment. Oftentimes I think that's a great idea. That's what we have. But two, I think it's just being aware that sometimes you can send those people to places just to get an evaluation. Because oftentimes people say, like, I don't want to go away for a month. Sure. How about we just get an evaluation? And I think it's couching it and framing it, especially for families and adolescents. It can be really accessible, saying, hey, I just want you to be seen by somebody. And just to hype addiction medicine, just got approved from the American Board of Medical Specialties on Monday. It's a big deal. So there's going to be lots more people out there that are getting formally trained in order to help us with this age group as well as adults. Triage factors that most people take into account when you're saying, what do you really need? Here they are. Key things in terms of what type and where location-wise do you need to go is relapse potential and recovery. If the home environment, if dad's an alcoholic, probably not a great place. It can be really tough to stop drinking if you can always just grab one or two from dad and he never knows. In summary, again, just kind of ask, assess using a validated tool, advising with a clear message, but oftentimes one that's not an aggressive message, just kind of seeing where they're at, asking them where they need to go, and then helping them get there. Oftentimes that just means follow-up, perhaps with medication-assisted therapy. I breezed through a lot of that. Oftentimes there's not a ton of data on the treatment options for adolescents. It's just a sparse field. That said, I can tell you more about kind of clinical practice and more kind of the underlying neurobiology going into this if you have any other questions. Thanks.
We have time for some questions. I wanted to just make a couple comments first. One of the things that we're trying to do in in terms of clinic and our populations, both adults and adolescents, is look at what we're doing for screening. What can we do to recognize whether there's a substance use issue or not? So those of you that were residents that were there yesterday, 3s, 4s, and the child fellows were soliciting your help too and looking at your population. So that's one of the projects we're looking at in clinic. And then once we look at that with residents, then we'll tackle the faculty. So that should be interesting too. One other comment is that we're adding to our faculty. So we will have Dr. Pamela Gonzalez, who was an addiction medicine fellow several years ago. She's a pediatrician, will be joining our department and in our clinic nearly half time. So she will be focusing on adolescent substance use. So she'll be another resource and asset to our faculty and clinic. All right, thank you, Dr. Grahan. Other questions, or questions, I should say.
Thanks, Brian. That was great. Thank you for all the work you've done and all the work you've done with my fellows over this last year. They've been very happy working with you, so I appreciate that. I did a review article on substance use and psychosis when I was a fellow, and it was very eye-opening for me. I was focused more on marijuana and psychosis, but something that I share often with my trainees that I think surprises them was, I believe it was a study out of Australia showing that just doing psychoeducation with someone and saying that I believe that this marijuana is contributing to your psychotic symptoms, half the people will stop smoking right then and there with just that amount of education from their physician. And when I ask, before I give that information, what percentage do people think that would be effective with, it's much, much lower. So I think often as clinicians, we underestimate the power we do have with our patients. But this was really great. Thank you.
Thanks for the presentation. There's a common instrument used in college students, the alcohol use inventory, the AUI. Mm-hmm. Is there any information on its use and or validity for adolescents compared to the CAGE and the CRAFT?
The AUI
originally designed for college students, but I wondered if they work backwards.
I can't think of a study off the top of my head where that crosswalk has been studied. So I'm not sure. I know there's more data on the problem, what's called the problem alcohol is out of Rutgers. There's been some work trying to correlate that with both a formal diagnostic assessment and the CRAFT. S2BI is too new, so the crosswalks haven't been done for that. The CAGE, there's more historical data, but it's hard to figure out what to think about that because we know that the CAGE is not a great screening tool to begin with. So I'm not, to your specific question, I'm not sure, but that's kind of how I'd interpret it. Yeah. Yeah.
Practice because many of the tools which are good or evidence-based, you need to buy the copyrights for those, or at least get permission and pay money for that. Are you aware of any free resources which we can use if we decide to work out in the community, which are good and would be helpful?
So I know that the S2BI, they're pushing it to be disseminated broadly. So they have a copyright, however, they've explicitly stated that they want it to be used just freely. Similarly, the craft, the Boston Children's was very explicit in saying they have kind of their sheets at the bottom will say copyright by, yeah, they say for clinical purposes, you feel free to use it. It's more if you use it for research purposes, then they ask you then to contact them and have some fees associated. But for clinical use, they've been very explicit saying use it.
Any other questions? All right, well, thank you all for coming.
You have been